Various trials have shown the merits of neoadjuvant therapy for patients with locally advanced gastric cancer. And as a result, we've seen a trend towards the use of neoadjuvant therapy in Europe as well as in the Netherlands, leaning more towards the approach we have been using for esophageal cancer over the past decades. Appropriate staging is obviously very important in guiding our treatment decisions regarding the use of neoadjuvant therapy versus upfront surgery in these patients. However, the accuracy of preoperative staging for gastric cancer remains largely unclear. Therefore, the objective of our study was to investigate the concordance of clinical and pathological stage, as well as its impact on survival in resectable gastric cancer patients. The National Cancer Database was queried for patients with clinical stage T2 to 4 gastric adenocarcinoma. We only used the NCDB until 2014 because we wanted to have sufficient survival follow-up for our survival analyses. Patients with any evidence of clinical lymph node metastases or distant metastases were excluded from our study, as well as patients who received neoadjuvant therapy, as neoadjuvant therapy may cause down staging. In addition, we excluded patients with any missing covariates. Upstaging was defined as having a pathology stage that was higher than the initial clinical stage, or having any signs of positive lymph nodes or distant metastases. We used multivariable logistic regression analyses to predict upstaging. In addition, to prevent selection bias in our survival analyses, we created propensity scores for the upstaging and matched patients one-on-one based on a propensity score. Survival analyses were performed after matching using the Kaplan-Meier survival methods. These are the baseline characteristics for the 2,900 patients we were able to include in our study. The median age was around 70, and the slight majority of the patients were male. Half of the patients were treated at academic centers, and 35% of patients had well to moderately differentiated gastric cancers. 45% of patients underwent a partial to subtotal gastrectomy, and the majority of the patients had more than 15 lymph nodes evaluated in accordance with practice guidelines. So on this left of the slide, you may appreciate the initial clinical stage of the patients we include in our study. 48% of patients had clinical stage T2 disease, and 39% had clinical stage T3 disease. On the right, you may appreciate the pathological stage. And as you can see, up to 34% of patients had stage T4 disease, which is substantially higher than initial clinical stage. So on pathological evaluation, 57% of patients had a similar stage. However, 24% of patients was upstaged on their pathological evaluation. So the most important predictor for upstaging on pathological evaluation was having an initial clinical stage T2 disease, as well as having a poorly differentiated tumor. In addition, there was some impact of the location of the tumor, but it wasn't really substantial. In addition, 47% of patients were found to have positive lymph nodes that were initially undetected on their clinical evaluation. And again, the most important predictor of nodal upstaging for these patients was having a poorly differentiated tumor. None of the other factors, including being treated at a low volume center, had impact on these findings. So 3% of patients were found to have distant metastases, either intraoperatively or under pathology. The most important predictor for having distant metastases found was having, again, a poorly differentiated tumor. But also interesting is that patients who received surgery more than 4 weeks out of their initial diagnoses were also at risk of having any distant metastases found intraoperatively or on pathology. And although our study doesn't span the COVID period, it may have some impact for surgeries that have been postponed due to the pandemic we're currently in. So this is the survival curve after matching. In blue, you may appreciate the patients who were accurately staged, and in red, the patients who were upstaged. And as you can see, patients who were accurately staged had significantly better survival, resulting in a median survival of 51 months, compared to only 30 months for patients who were upstaged. So this study has several limitations, and I think first and foremost, we couldn't identify from the NCDB which preoperative staging methods were used, which obviously may impact the accuracy of the findings. In addition, various centers may use various pathological examination strategies, which also may impact the stage. And the NCDB only provides information on centers that are Commission on Cancer approved. And although these centers cover approximately 70% of all cancer diagnoses in the United States, and there are some high volume centers that also don't provide data to the NCDB. I think the majority of patients that aren't included in the study are likely low volume and probably have a larger stage, less experience in a larger stage discordance than actually reported in our study. So in conclusion, there's substantial discordance in clinical and pathological stage for patients who received upfront surgery for locally advanced gastric cancer, with 24% of these patients having a higher T-stage on pathological evaluation and 47% of patients having lymph node metastases found that were initially undiagnosed on our clinical imaging. Inappropriate staging may misguide treatment decisions, especially regarding the use of neoadjuvant therapy for these patients. Further studies are necessary to improve our preoperative evaluation. In addition, I think these data provide some evidence for a broader use of neoadjuvant therapy for patients with locally advanced gastric cancer. Thank you. I'm happy to take any questions.
Thank you very much. This paper will be discussed by Dr. Kawaguchi.
Oh, thank you. First, I'm sorry for my trouble about the connection. Now I can talk and I can see. I congratulate the great work of Dr. DeGray. I have 3 questions about your study. First, we may not completely avoid the discrepancy between clinical staging and the pathologic staging, as you talked. What kind of modality include this discrepancy? This is the first question. And second question is, you recommended the use of neoadjuvant chemotherapy for gastric cancer. However, the evidence supporting neoadjuvant chemotherapy is not established. Is neoadjuvant chemotherapy superior to upfront surgery and the post-operative adjuvant chemotherapy for upstaged patients? This is the second question. And the third question is, the survival of patients with pathologic T upstaging was quite low compared to the survival of patients with accurately diagnosed pathologic T-stage. That you reported 30 months versus 50 months. I think the evaluation of survival of pathologic T upstaging may be insufficient using propensity score matching analysis, just adjusting for pathologic T upstaging because other covariates were not adjusted. Did you assess a Cox proportional hazard model adjusting for other risk factors, including pathologic N factor and the use of adjuvant chemotherapy, for example? Again, I congratulate the great work of Dr. DeGray.
Thank you for those great questions. So for your first question regarding the staging modalities, I think one of the major limitations of using the National Cancer Database to actually do the study is we don't have any further information on the imaging modalities used. But it will be very interesting to have more detailed information on that. And regarding your second question, regarding the use of neoadjuvant therapy, I think you're absolutely right. And I think I've been assuming a little, like this study excluded actually all patients who received neoadjuvant therapy. So it's hard, but yes, I'm drawing conclusions for the use of neoadjuvant therapy. And we still haven't, although some trials point towards the use of neoadjuvant therapy for these patients, they haven't been conclusive. And the European guidelines already support neoadjuvant therapy, but I think the NCNN, the American NCNN guidelines still leave it open to the physician for patients with, I think, stage larger than 1B. So you're right, we actually don't have conclusive evidence with that regard. Although I think still more and more people are using neoadjuvant therapy for these patients. For your last question, the survival and the upstaging at the median overall survival of 30 months compared to 51 months. So we use propensity score matching because I think the patients who are upstaged are very different for the patients who weren't upstaged. And in theory, you would prefer propensity score matching over using a Cox model. And to create a propensity score that's used for propensity score matching, actually factors like the end stage and having this metastases were included in the propensity score we use for this model, as well as other factors like age and comorbidities, having other malignancies that may impact survival. So Thank you. Did it answer your questions?
Yeah, perfect.
Do others have questions?
All right, just a super quick question. So we just did the same study in pancreas and found almost exactly the same thing. And our conclusion was to recommend neoadjuvant for all. And we're actually doing that for gastric now as well. And our data are coming up soon. My only question is, in your reading, did you see anywhere of any specific imaging modalities that maybe would downstage as opposed to upstage? We didn't find anything for pancreas that showed that preoperative imaging would ever go on to be downstage pathologically.
I think that's a great question, and I agree. We actually had the same problem, and we looked for it, but we couldn't find anything either. Yeah, and also I've been probably overlooking the patients who were downstage in our study. Yeah, we also had like 18% of the patients who were downstage in the pathology evaluation. Thank you.
Sorry to put in front of our keynote speaker.
Oh, no. I was going to say that Motaz guy is pretty smart, because that was going to be my question. I know, our group published about 5 years ago on about 1,000 gastric cancer patients from the U.S. Gastric Collaborative, and specifically looked only at endoscopic ultrasound and found only a kappa value of, I think it was like 0.28 for the T category and 0.33 for the N category. So my question was the same. Should we abandon our attempts because we are so inaccurate with adequately staging these patients, just to move more fully into just embracing neoadjuvant?
That's a great question. And actually, I completely agree. I think we should just give these patients neoadjuvant therapy. But there seems to be still some reluctance. There's still many people who prefer upfront surgery for these patients. So maybe, why do you think that is? Why are we still where are there still centers who are committed to upfront surgery for gastric cancer patients?
I love it when you ask us questions. I think some of it is, personally, I think it's patient driven. Patients want an operation. It's hard for them to wrap their brain around delaying an operation. And I think it's been my experience in the community where the referral patterns can be competitive. If you don't operate on that patient, someone else will. So I think that sometimes, unfortunately, drives when patients have their operations.